Ron, Trinity. I'm going to get going in that case. So hello, everyone, and welcome to the 2024 collaborative series of webinars between PxP, which stands for Patients by Patients, and the Patient Engagement Research Ambassadors at the CIHR, which stands for the Canadian Institute of Health Research, specifically the Institute of Musculoskeletal Health and Arthritis. My name is Ellen, and I'm a fellow patient, and I'm a research trainee, and I'm truly honored to serve as your moderator for today. This webinar is the first in a 4-part series that we'll be hosting in 2024. The webinar series is a part of our continued effort to build capacity and skills for those in the patient engagement space. This is specifically between PxP conferences, with the next one being held in fall 2024. Please note that most of our hosts and speakers identify as being patients, but we do realize that different words, different places, for instance, patient partner, patient engagement, consumer, patient public member, patient and patient involvement, these words are all used, but we acknowledge that, together we are here to talk globally about the diverse lived and living experiences of individuals who are working with researchers in research as partners. So while this webinar has been designed for patients by patients, of course, we welcome others to join us. So huge welcome to everyone. And thanks to the webinar's supporter, the Canadian Institute of Health Research and the Institute of Musculoskeletal Health and Arthritis, that is located on the traditional, ancestral, and unceded territory of the Coast Salish peoples, namely the Musqueam Nation. Myself, our panelists, and the organizers would like to acknowledge that although we meet today on a virtual platform, we have participants joining us from across the province, the country, and beyond. We'd like to take this moment to acknowledge all the Indigenous peoples of Canada from coast to coast to coast. We acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that have called this land home for many generations. And we encourage everyone to leave your land acknowledgement in the chat. And before we begin, a few housekeeping items to mention. Today's webinar will include introductions from our panelists, a little bit of a primer of the research cycle and patient engagement in research, and then we'll have a conversation with our patient partners who are here with us today. We're going to encourage you to use the Q&A function on Zoom to ask questions. We promise to get to as many as possible. We'll say, please use the chat function to share a little bit about yourself if you have any resources you'd like others to know about. And you can also react to what other people say. You can show your support. You can add an emoji. And the new thing about Zoom is that there's closed captioning that's available. So if you look at the bottom of your screen, there's a CC button. And if you click on it, you'll be able to select the language for your captions. And note that this webinar will be recorded and will be available on the PxP website shortly after today. And most importantly, I want to ask you, I want to encourage you to continue the conversation with our hashtag there on screen. All right, so with that, I'm going to now turn it over to our panelists, Trinity and Ron, to introduce themselves, and then we'll go back and do a little bit of a research overview.
Thanks, Ellen. So my name is Trinity, and I'm from what we call Ottawa, which is also the traditional unceded and unsurrendered territory of the Anishinaabe Algonquin First Nations. And I am a student right now in my last year of university at the University of Ottawa studying nutrition sciences. I also have lived experience as a patient partner and as a patient, especially in the realms of nutrition support and rare disease. And my research experience started mostly as a patient partner around 2020, doing a few things there. And since then, I've been a member of a few different research groups and patient partner advocacy groups, especially advocating for the youth voice and championing quality of life outcomes for patients involved in research. So that's a bit about me, but on to you, Ron.
Thanks, Trinity and Ellen. Greetings, everyone. I'm Ron Beleno. I'm actually not in Toronto, Ontario, Canada, where I'm usually at, where my home is. I'm out here in California and Nevada visiting some family at the moment. But the beauty of having technology is that we can meet here from around the world. And I'm kind of quite excited about this because a lot of the conversation we're going to have today is related to patient engagement and research coming from Canada's perspective. But I am curious if people around the world or elsewhere, please share some of your best practices or responses to some of the questions that you're going to see earlier. As for me, I was a caregiver. So to me, patient engagement also includes many times that caregiver, or that could be also called across the pond, carer. So I think that's popular in Australia and in the UK, care partner, caretaker in some places. But I was a caregiver to my father who had Alzheimer's back from 2007 to 2018. And it wasn't until 2015 that I met my first researchers in the community. And that's where I was just sharing my stories. Eventually, when you share your stories, people start asking you more questions. And for those that are patient partners, kind of like Trinity here, as well as Ellen, those stories start shifting, which we'll talk more about later. And my story started shifting to not just telling the story, but actually getting more engaged, having opinions, suggestions, and then eventually getting involved with many research teams. One research group that I'm quite connected to is AgeWell, which is here in Canada. AgeWell is Canada's technology and aging network, where I co-chair the Older Adults and Caregiver Advisory Committee. And one of our priorities within AgeWell is that every project, whether it's research or innovation, requires that a patient, partner, older adult, a caregiver be on that advisory team. And we're not just talking about as panels for panel sessions or interviews. We're talking about to actually be part of the co-design, the planning, the ideas, knowledge translation, mobilization. So that's one of the groups that I'm with. And there's a few more that I'll share later as we get into the discussion further.
Thank you, Trinity and Ron. Very, very exciting, your work. And I can't wait to learn more myself. All right, so let's jump back into just a little bit about the patient engagement space as it currently stands. All right, so let's just make sure we're all on the same page. We're going to use the Canadian Institute of Health Research, their definition of patient engagement, and they use the word meaningful collaboration through active engagement. This can be in the governance, the priority setting, developing the research question, and even performing certain parts of that research, so the doing of the research. And who is a patient partner, you ask? Well, patient partners are those with personal, living experiences of health issues, or perhaps they start as a part of someone else's health journey. And research teams are usually large, and they include patient partners, researchers, clinicians who are interested in research, trainees or students like myself, as well as research coordinators and other individuals who help to move the research along. And I'm going to say, generally speaking, researchers and clinicians tend to design the research study, while students or trainees and research coordinators carry them out. It is a team sport, and one that patient partners are becoming more and more engaged and active in. And when we say research cycle, we often mean the storyline behind the research. So usually research starts when we have a problem or a gap in research. And then we move to gathering information about that problem, which is a fancy way of saying we start to ask questions. We can ask a search engine that questions. We can ask individuals or experts in the field different questions. This allows us to then set objectives, which is another word for goals, right? We have goals for research. So what do we want to learn from that research? And then we develop the research plan. So what are our steps that we're going to take towards that research? And depending on the project, it may also be appropriate to apply for funding at this stage, which funding can come from, for example, the Canadian Institute of Health Research. It can come from different charities, different patient organizations, and other sources. And then we usually take our research goals and our research plan to experts, including patients. We ask them for their feedback, we ask them for their input, and then we revise those goals and that research plan accordingly. The next step is the doing of the research. And this step specifically, more and more patients are becoming involved. So at the actual doing of the research, as researchers say, we gather data. The next step includes sharing research findings, which means we take what we learned and we put it in conferences. We publish it in academic journals. We give talks to our community groups. We share it with our best friend. And as many of you know, patient partners have really become leaders in this step. And finally, we evaluate our research. So we see what we did. We then ask ourselves, can we improve it? Or we ask patient partners, can we improve it? We get everyone provide their feedback so that next time we go through this cycle one more time, hopefully we've worked out a few of the issues we had previously. So now that you have this in mind, we're going to begin the Q&A portion of this webinar. A kind reminder to everyone to submit their questions using the Q&A function as they come up, and we will do our absolute best to answer as many as possible. In the meanwhile, I do have a question to start. So Ron, I'm going to start with you. Ron, I'm going to ask you a little bit about your journey. I know your journey has been very extensive and you have so much experience, but tell us about, your journey of getting to be a patient partner and especially where you are today as a patient partner.
Well, thanks, Ellen. So timing sometimes does matter when you're a patient partner or whenever you're dealing with patient partners. Many times we're not just one group where, okay, you're a patient and, one word we're going to be talking about here, and a lot of you, I think, are champions of this in this space already. You'll know when I bring up the word tokenism. Okay, so just something to keep in mind that if you're properly doing work with patient partners, you don't just grab a patient just so you could cross it off, right? And you kind of have to know where they're at as well. Okay, we're at that stage where there are so many excellent patient partners at different stages, and you got to know how they got there. So that's always important. This question is, how did someone get to where they're at this stage? I'm going to do a plug here. I'm sneaking that in right now because I've seen a few people online here already chatting. I see Elise and Annette that's on. I'm just going to put Patient Advisors Network. .ca. So that's one group that I was quite involved in earlier on. So yeah, so pretty much many patients go through, or caregivers for me as a caregiver, their journey. We're going through our journeys in life. Dad got diagnosed in 2007 with Alzheimer's and then passed away at home in 2018. Along that way, you're kind of many times advocating, telling stories to other people. Oh, this is what happened in our journey and the healthcare system many times. And then it wasn't until 2015 that people started reaching out to me because they knew a lot of my stories. A lot of my work is related to caregiving with technology, with tools to keep someone safe at home or to age in place. I didn't realize how important that was to say, how are you caring for your dad at home? How are you using Skype to remotely care for him, for example? The more I started speaking about my examples, eventually I ended up at a table with two researchers. Okay, and I thought they knew the answers. Okay, I said, "Oh, you're the researchers. Okay, so tell me, how do I do this?" And they said, "No, we're here to ask you the questions. Okay, because it seems like you're the one that gets it more than we do." And then that's when I realized that I said, is this how it works? And these were the top researchers in the field that I work in. And I said, oh my gosh, if you guys don't know it well enough, and why are you even spending that money on that research? That doesn't make sense to me. That's when we started realizing, hey, there's this gap that, the lived experience or those that understand their challenges as they get through life needs to be shared better. So it was around 2015 that the community of Age Well, as I mentioned earlier, that was the first research community that reached out to me that said, hey, can you come on our advisory and start discussing what's going on and how you're dealing with that? And then as time went on, I see another group like, the one I linked there, Patient Advisors Network, plus a few others here and there, with all these patient voices starting to speak up louder over the years and trying to say, we got to do this better, whether that's in healthcare, whether that's research, whether that is with innovation. That's what started happening along the way. I love mentoring others, to kind of say, hey, this is a way to talk to some researchers. This is the questions you have to ask. This is how you speak up, right? So has happened over the years since 2015. So I would say 9 years now. I'm getting to my 9th year. I've lost count. I know I'm at least past 50 to 70 research projects over time at different levels, of course, and most of it is again around aging, but a lot now in primary care. Diabetes happens to be another area that I'm into as well, that I'm connected to. And here in Canada, you mentioned SPORE, Strategy and Patient-Oriented Research. So I'm on the board with the Ontario SPORE, Strategy and Patient-Oriented Research. And there with, like, let's say a CEO from a hospital with a lead researcher. So it's that's where I'm at those tables, getting to the tables, and then making sure that we can get others to the table. My interest right now is to bring that diverse piece. Okay, the diversity, yeah, there's many voices not making it to the table, which many of you already know. And they want to be at the table. It's just a question of how we do that. I think that there's some barriers, some gaps and all that we're going to keep working on.
Ron, thank you for your work and most importantly, your advocacy, right? You saw the gaps and you stepped in there, and it's incredible that you took those initiatives and really mapped it out for other people, right? Like, it's truly groundbreaking work. So very, very exciting.
Ellen, I need to bring something back on
yeah,
that.
please.
One of the things that you said that, and I appreciate that, but it's actually us learning from each other. Like, again, there's patient, I don't know if everyone gets to see who's online here, but I'm seeing it here. I'm saying, wow, that person taught me this person, together, we sat together and worked on this together. So it's kind of, we kind of built that it might look like maybe one person here at this table, but the beauty is patients are rallying with each other to help move the work forward. And that's actually much better, that it's not just one person. It's a little harder to do that way. So, but thanks, Ellen. I get what you're saying there. Yeah.
Thank you, Ron. And Trinity, please share with us your journey of getting to where you are.
Of course. So just like Ron, it's never straightforward or linear, and there's a whole bunch of little side projects along the way. But for me, I started after a pretty bad experience in the pediatric system. I transitioned to the adult system over the COVID pandemic and was really looking for a place where my voice could be heard and listened to. And so that was when I found an opportunity for some youth to share their experience to a research team, and they'd be compensated with a gift card. And at that time, I was financially motivated, and little Trinity back then jumped on that opportunity, and it was a short little series of forums. And from there, they were asking for a youth advisor, a few youth advisors to apply to join the team. And so I applied for that. And then from there, started working with C4T, which has gone through many name changes throughout the years, but is essentially a Canadian collaborative for childhood cannabinoid research. And so being a youth advisor there on a few of their projects, I was able to speak at some conferences about the importance of youth in research and really how important actually listening to the youth perspective is. And then from there, of course, it opens up a big networking opportunity. Was able to hop on a lot of other projects, but mostly around the importance of listening to youth in research and a few clinical trial things here and there, as well as being involved with my local hospitals and really just looking over some of their research projects from the patient perspective. And it's taken me to where I am today with a few little sidetracks along the way, but I'm really passionate about making sure that researchers understand the patient perspective. Um, so that's a little bit about where I came from.
And Trinity, I just want to appreciate how there was one opportunity that interests you, and then, that led to the next thing, and that led to the next thing, because it's a similar narrative to what Ron was saying, that, you never know what's going to be there through that door. And I would love to add on to that a little bit. So why would someone, Trinity, want to be engaged as a research partner?
So there are lots of reasons, and there are definitely some reasons that you need to evaluate and think, is this really the best time for me to be giving back to research? For example, some people might have gone through a negative experience in one aspect of their healthcare or as a caregiver, and then want to change that in research. But a good moment to do that would be once you're past your own personal issues and ready to give back to the system. If you're still caught up on those like personal issues and finishing things back with what went wrong, that's not exactly the best time to be giving back to the system. But for me, there were lots of reasons. And I think one that isn't touched on a lot, especially in the youth population in research, I talked to some other youth partners, is really just the personal benefits of the networking and having something to put on your resume. When you're young, those opportunities are pretty hard to find. And so for people like looking to go to med school or further grad school, or even anything academic, having those publications on your resume is a huge perk. And so that can definitely motivate people. But really for me, it was a lot of the giving back and the learning from other people and the research team. And just for me at such a young age, being able to have my name on so many publications and speak at conferences and all of that, I'm really motivated by the learning and by the research. So for me, that was really what kept me into it. But I'm sure for Ron, it's probably a different story with some overlap there. So I'm curious to hear from him.
Ron, please share with us.
Yeah. Trini, I like the point that you mentioned with regards to the way I explain it is we have all our stories that we are sharing, and many times many patient partners are still living it, or they've already gone through it and they have time to reflect and all that, right? So that's why I say one of the things we really need to do from the research side, for trainees or seasoned researchers, is you really have to ask the questions with who you're potentially going to bring on board as a patient partner, as to their story and their history a little bit. Okay. And, because sometimes there are patient partners, we love you all, but some of it is you're just thinking as yourself, telling your story and your own issue, and maybe not realizing that this is for a bigger population, that you're representing a group. Actually, you're not just representing yourself all the time, right? So a research team, at this point, in my opinion, should also say, is this potential patient partner someone who is, if that's what they're looking for, what I'm saying here is if they're looking for someone that's very new, still very raw, that's great. And if they can onboard them and bring them on board and educate them and coach them and support them in some way to be that better patient partner on the team, that's what I'd be looking for, that research teams do, that they have some kind of support system as the patient partners get on board. For myself, it was just one of those where, again, it comes back to that story, and we keep growing along the way. I don't think it was initially as an advocate. It was just one of those where, oh, you keep asking me questions? Okay, I'll keep giving you answers. And at that time, it was a little bit, I loved saying yes to all this. It was just exciting for me. I do love that question, that how you started off, Trinity. It's kind of like there was a little bit of a financial incentive for you to be honest, to tell us that, okay? Because it's one of those where that needs to be discussed as well. What is the reason that they're actually interested to coming on board, versus many times researchers say, hey, can you come on board? We need someone with your experience, versus what's the win? Okay, what's the win-win-win, for everybody? Okay, is it growth? Is it excitement? I'm gonna, Ellen, I think because we do have the time, and I know we had another patient partner that was supposed to join us, so we do have a little bit more time here. I'm gonna sneak in Sue's question earlier,
Do
which
it.
is really, okay, so Sue, you had a question, I think everyone can see that there, about pissing off the researchers. I lost track of that somewhere, if someone sees that. How do I know if I pissed off a prospective researcher by, by talking about accommodations I would need versus did the research back out because they determined there was not enough funding? This is interesting how you frame that, because did I piss off a prospective researcher? Meaning that you maybe, Sue, you were the one that was prospecting for that researcher. Many times usually doesn't happen that way. It's usually they're looking for us. So that's how I'm interpreting it. But I have no problem personally pissing off the research teams. Not that that's intent that I'm going in. Okay, we're the ones with the value, with the gold, in my opinion, to help move their work forward. Okay, again, this is Ron's opinion, so this is how you guys take it there. Everybody listening in. So part of that is really disclosing what is it that you need to be a partner on this team, to collaborate, right? That's, is it some financial support to be there, right? Is it that you need to be able to, I think you're asking, some kind of accommodation, I believe that's what you're looking at. Something, yeah. So that, I believe, has to be shared. Now, if they don't have that, then at least you can move on from that earlier. It's worse that you get into a relationship and then halfway through or later on, they said, oh, we can't accommodate that. And you're kind of like hanging in there with them, right? So it's okay, Sue, to keep moving on. But someone did comment a great comment that, yeah, you had that conversation. Is there a reason why we can't, or we weren't able to move forward with this, right? So I have no problem, and I'm going to suggest to everyone is to say, be a little more cocky. That's, in where you're at. And when I say cocky, Canadians are not cocky people, but just say, hey, I have value. Just let me know, what was the reason for this not happening, right? And be able to just say, okay, I got to learn from that. And maybe you could learn that, hey, if you're going to do a project like this in the future, reserve a higher budget for that patient partner, a percentage. Okay, many still don't do that. They forget about that until later, right? And they said, oh crap, we don't have the budget to support you on this, but you're already on board. So that's kind of my response there, Sue. Just, yeah.
Thank you, Ron. And
Exactly.
Yeah, go ahead, Trini.
Sorry. It's honestly the loss of the researcher to have lost you. And if, say, let's take, for example, the reason the project didn't go forward was because they weren't going with that accommodation, it's really a reflection on them and not you at all. And it really just shows that if the project had gone forward, it wouldn't have been a successful collaboration, and they probably wouldn't have listened to you as best as possible, and you wouldn't have been able to give your best to them. So we'll just say it's for the better, probably, that it was their loss, and you still have so much more to give to other organizations who are actually willing to work with you on that. So your accommodations are like what's set in stone, and that's not something to kind of give up on for a project. So to definitely like be strong in those accommodations and advocate for yourself, even when it's hard. But that's really what you deserve.
Exactly, Trinity. I was just going to say, again, echoing back what you and Ron have said, I want to dive a bit deeper. So if there's a researcher and say they're newer to patient engagement and they want to onboard a patient partner, do you have any key tips or considerations they should have in mind? And Trinity, I want to pass it back to you. Anything that newer researchers should have in mind when they're onboarding patient partners?
So I've had a variety of experiences, some where I was new to a new organization and there was really no onboarding and we were just flying by the seat of our pants, whatever the phrase is. And that was one experience. And then other experiences where it's a very established team and they have like a procedure to go through and you have to check all these boxes for the onboarding process. And honestly, neither is like better than the other. The thing that makes it a key onboarding process that actually works, number one, I think to assume competence in youth patient partners, caregivers, a lot of times, especially as a youth partner, I find that we're kind of talked down to, and it's assumed that we don't know lots of things, when in fact, we're here on this team because we have value to add. And also we do have lived experience, like we do know medical words and things like that. Like, of course, it's nice to have things available if needed, but a lot of times it's almost infantilizing. So to definitely assume competence in the people that you're working with during the entire onboarding process, and not to really like treat them like they're smaller, but then also um, to give them as many opportunities as possible without necessarily forcing anything on them. So to assume competence and to give them opportunities to, say, attend conferences, send them articles that are relevant to the research project, anything like that. And I also understand that no is an okay answer from patient partners and also from the research team. Like, no is an answer. And you can ask for something or you can give someone something. And if they say no, that is okay during the onboarding process. And another thing, one last thing that I'll just add to this, lots of good projects that I've been on, they really include patient partners in like a ladder stepwise approach where it's the patient who decides, or the partner, caregiver, whatever the discussion has decided that we want to call it, who decides how much their involvement is. And then that will also determine their compensation and things like that. But it's really up to the patient partner to decide, do they want to be involved in writing the manuscript, if that's an option? Do they want to actually do data collection, if that's an option? Or do they just want to consult and be at a meeting every 6 months and really give their opinion? So there's tons of different ways for people to be involved in. And I think during the onboarding process, that's when the discussion needs to happen about what the opportunities are and where the person being onboarded can actually contribute.
Really, such an important point. I just want to double highlight there that involvement can look different. And Ram had said this earlier. It can be at different stages. It can be different commitment levels. It can be in different, like you have expertise in one specific area. It does not have to be this like linear yes or no. So thank you, Trinity, for touching on that. Ron, I'm now going to throw it over to you.
Yeah. So before I give some of my suggestions with onboarding, I want to say that is a critical moment where we also lose many patient partners, okay, especially the new ones, that it takes that first one or two, I don't like to use the word bad, but just not unsupported, poor experiences, that they were not onboarded well, especially the new ones, but even those that are seasoned as well, that they're not onboarded properly to be introduced to the team, to be welcomed, to have even that voice properly on the team. And that's where we lose the potential of so many great patient partners that are now gone just because no one really onboarded them properly. So I wanted to make sure that people who are here as researchers or the young trainees to understand that is a critical stage. It's kind of, again, like it's relationships. A lot of this is about relationships and relating to each other with respect. And if there's this power dynamic, I saw it there, I think Elise made a comment or someone else, that when you're labeled patient partner, that you sit at the table, the virtual table, in the room, or wherever that may be, and you'll feel it that, oh, I'm just kind of like this little person that's coming across, right? Or no one kind of gave me my voice until the very end when most of the meeting was done. It's okay. So Ron, your thoughts. And it's just like after the fact. So for me, so some tips with the onboarding, I would kind of suggest is that there should be, again, a champion, one or two possibly on the research side of the team to spend and have a minimum 30-minute chat, okay, video chat ahead of time, okay, to kind of just really welcome them and get an idea of who they are and tell them these are the people that are also on the team. Okay, I'd like to kind of know who are these people. I'm going to just see their faces for the first time, and I'm saying I have no idea who this person is or what their role is. Okay, that is something that is really important, that we could have a little background information as to what the makeup of the whole team, okay? And to say, okay, well, what would you as the patient partner be contributing? Okay, this is what we're expecting for you, Trinity, to contribute. And let us know if you're comfortable with that. Are you comfortable to talk about your story? Are you comfortable to talk about your experiences? And also, are you a shy person? Let us know how we could make sure that your voice is heard. Okay, so those are in meetings. And then another piece of onboarding for me is that someone is checking up on that patient partner, okay, on the side. Okay, it's kind of like that water cooler conversation. Sometimes the best conversations are not during meeting time. It's when, oh, it's break time, you're just stepping to the side. Someone's just checking how's it going along the way, okay? So that to me is really important, those side conversations. And I will also say, I always bring this up in every conversation, just to talk when it comes to relating to people, is asking the feeling question, okay? I go straight into the feeling, saying, so how are you feeling, with this team? How are you feeling being here today? Or how did you feel getting over here? When you ask for the feeling question, for me, you could kind of say, you're gonna feel, hopefully, researchers are not robots. We're not dealing with AI researchers, we're dealing with human beings that will say, oh, I'm sensing you're not, really feeling something here. And then you can reverse engineer to say, oh, is it because you had difficulty getting here today? We didn't realize you had to do all this work just to make it to today's meeting, something like that. So that's what I'm throwing about when it comes to onboarding, to kind of really understand that person by asking them some questions, more powerful questions, engaging them throughout, and then bringing up feelings if you're willing to do that.
There's something so authentic about having conversations that aren't scripted or aren't within the 1 hour meeting, like before and after. And I think you bring up a really great point about, as you said, building relationships and the importance of having the outside conversations. And I want to go back to a point, Trinity. I know that Ron touched on this word, so this word tokenism, that we've heard it. We most of us kind of know what it means. Could you, if you don't mind, do you have any experiences of this? Any thoughts on this word? Anything we can do to avoid it, perhaps?
Absolutely. So I think for me, the best example of tokenism to really get it across in the most basic of terms has been on a research project. We were building a space and somebody asked me, Trinity, you're in a wheelchair. So what height should we have the countertops for people in wheelchairs? And I just looked at them like, okay, I am one person in one wheelchair who needs a countertop at around this height. That would be completely different for somebody else in another situation, which would be completely different for somebody else in another situation. You can't just ask one person their experience or what they need to represent an entire group, especially a group that's very diverse. So overall, tokenism just looks like really using a patient partner to check off a box, as Ron described earlier, and to not even check off that box properly. So it really, to have non-tokenism, or to really be anti-tokenistic in your research, it would look like really using patients and understanding that their experience is their experience. Like, it's one person's experience, but using that in a broad sense can really help improve research. And the patient partner also needs to be heard on the research team. And being heard really looks like having their ideas implemented or taken forward and have a discussion about them. There have been some times on a project where myself or other youth partners have brought up an idea for it to just be shut down immediately by someone just because we were youth who don't have a PhD. And because of that, it felt very tokenistic, our involvement there, because what were we doing on the project if none of our voices mattered. So to really be on a project where our voices matter is something that feels really good. And because of that, we're actually able to give more because we trust the team more. So that relationship really builds both ways. There have been plenty of groups where myself and the other youth partners are like texting behind the scenes at meetings, kind of like, oh my gosh, they're not listening to our ideas. Like, what do we do? Who do we bring this up with? But the best meetings have been the ones where I'm not texting with the other youth because we're not being heard. So that's really what makes it non-tokenistic, is to actually be listened to in a meaningful way. And that's not something that the research team can just pretend to do. It's something that they actually have to actively be doing and believe in it too. So there needs to be a buy-in from the research team in order to achieve that.
Yes, a genuine buy-in. I think the example you gave illustrated that really, really well. And it goes back to what Ron had said, something, our first meeting, he had said, not just about sharing your experiences, it's about listening to opinions as well, right? Not just for, you want to be gauged, not just for your lived experiences, but the ideas that you've developed because of those lived experiences, the insight you have because of those lived experiences is equally important. Now, Ron, I'm going to want to throw it back to you a little bit about interpersonal skills. So Trinity just touched on, for example, some of those soft skills. We call them soft skills, but key skills to developing relationships. Can you perhaps elaborate on what some of those key interpersonal skills that researchers might want to work on?
Whatever we call it, soft skills and all that. Again, someone put it here, I think it was again Elise, who I really respect her, Elise maybe. But the concern about transactional relationships, that is this just transactional, right? That's why I kind of throw it out. Are we just data, and here we're just giving you the data and then that's it? No, the key word for me actually in all of this conversation really at the end of it is the I word in my world, is the impact. Okay, research is still going to happen with or without us. Okay, that they're good, there's always been research. Now it's growing, it has been growing, where the patient partners are. Again, just for those that are here, and I believe the majority of the people that are here know that we're talking about patients engaged on the teams, not patients, for research, on the research side of collecting data, panel sessions, like that kind of stuff. So we're talking about being on the research team. And part of that are people skills, okay? Communication skills, the ability to, use your senses, hear, but also body language. So there's many ways, even in Zoom calls, you could tell if you're really paying attention, when someone's really like, oh, they just said an acronym and they're processing something, right? They're like, what's, and you could tell sometimes when a patient's getting lost, if you're really paying attention, or you just simply check in, is everyone okay? And they understand what we're talking about here. So the skills, I actually think body language is huge, okay? I suggest to people, and researchers struggle with this, the researchers I know, many of them, and students, they said, oh, I don't know if I want to take that class. So I'm suggesting improv, okay? I know that might not make sense here, but I tell people, take improv, okay? Improv means, what the first rule of improv is, you always say yes and. You always have to accept what someone is saying or what they're delivering to you, okay? And if you're not able to do that, okay, then you're really not paying attention, okay? Sometimes if someone's saying something and you say, yes, but this, well, no, that's not how improv works. Improv is yes and. We're always adding and supporting each other, whatever you say. But you have to truly say, yes, I am actually hearing, seeing you, feeling what you're saying, and I see where that goes with our teams, or with our work at this moment, or whatever we're doing. So I am throwing out improv. It's kind of a unique one that people would always stare at me and sometimes say, what does that have to do with research? I said, it's actually a superb skill just for life, but for research, especially with patient partners, it is a very unique skill. I suggest maybe we someone sets that up, as part of the onboarding of their training, whoever does that. And we go the yes and thing. How do we do that? Okay. And you'll see, I bet you if we had an improv group where it was a mix of researchers, senior level leaders, the young trainees, and you'll see who's struggling with yes and, but that's not right. That's not how we do it. And no, this is how it should be. Chances are it's not going to be the patients. The patients will be accepting. Many times it's the younger trainees because they're still learning, they'll accept it. So that's one of the tips I'm going to throw out is how are you really paying attention and receiving the other side? But on the other end, it's also the patient partners if they are onboarded. And they may not be onboarded through the research team. It may be patients on teaching other patients. Okay. There's Pan. I'm going to give you, oh, someone put OMG. I've got to try this. Okay, there you go. Sorry, I'm putting a couple of links in here as well. But there are, someone asked earlier, are there, methods of onboarding? Yes, there are many that are doing that. I'm just giving you a few here, CIHR. I do some work with McMaster on primary care about onboarding, stuff like that. But it is one of those where at the end of the day, for me, it's the ability to say, hey, I'm hearing you, you're hearing me. We communicated. Now that we understand it, let's go create that impact on this project much higher than without us having you on board. So yeah, that's just one that I'm thinking of right now.
Ron, that one's a great one. I love it. I love the simplicity, and I think you highlight through your comment about improv that it's an art. It's not a science. It's not a checkbox. It's not, if I do this, I will get this outcome. If I ask the patient partner if they can be involved, they will follow the lead. It's not that. And yeah, it's also something that I'm like thinking about myself. I'm like, wow, I do that as somebody who's doing research. So thank you personally. And I would love to ask, so if a patient partner wants to get involved in research, like how do they take those first steps? They think they're interested. How do they take those first steps with, someone with lived experiences, someone who perhaps has done advocacy work, has seen or been a part of PxP, but wants to now get involved? Do Trinity or Ron, do you guys have any tips?
Go ahead, Trinity.
Thanks. Earlier in the chat, Amanda shared a link to a youth in research Instagram page, which is where I personally find a lot of opportunities. They really just share a lot globally about any opportunity for a team that's looking for a youth. They reach out to the Instagram page and it's published there, which works great for youth. But I feel like the demographic on this call might not be 100% youth. So for other people, there's usually opportunities that are open a lot, but a big part of it is networking. So a big part of it is already getting one foot in the door. And by already being in this webinar, you definitely have that connection somewhere and are involved somehow in something. So to continue on this right path of, you're involved, you found this webinar, wherever that was, that's the place where you'll find more opportunities. People are always looking for more researchers. Researchers are always looking for more people with lived experience. A great place to start is your local hospital. They should have a committee of patients or caregivers who give feedback on things, but this also includes feedback on research that the hospital is doing. So I know for me, both my pediatric and adult hospital in my city have this opportunity to consult on research projects that are local and meaningful, and that could be the one step in the door that you need. Do you have any other ideas, Ron?
Yeah, so there's a lot, and again, there was no one path to doing this, so we're giving just a few here. The first thing I'll say for those that are, new to this, potentially wanting to be involved with research as a patient partner, as a caregiver, lived experience, whatever word you choose, is to kind of really know what is your fuel that pushes you to kind of get pissed off or get passionate, like, okay, this, right? It's more important. It's part of that win for patient partners to know that, hey, this makes sense to me. This is a world I relate to. There's no, my dad, had Alzheimer's. I was dealing with caregiving to someone with Alzheimer's. That made sense to me. That was a world that I understood, Trinity, I wouldn't know some of the challenges you would go through. So for me to just kind of, I'm going extreme here, to do something, for in that space, I'd be cheering you on, but it's not something I'll just say yes to. Previously, patient partners I see a lot just say yes to research that I'm saying, yeah, that's because they ask you and they only know who you are, and you're their default patient partner to ask. And that's not really the best way anymore. We've grown, okay, so back in Canada, here in Canada, we've grown that there are so many patient partners ready to go, okay? And the research community, in my opinion, has heard enough that, hey, we should be getting patients on board. Now, are they doing it well? Not, they're all at different stages, but there are many patient partners that are ready to go. And I would suggest to any patient partner to kind of say, hey, one, if you're on social media, just look up who's doing work in that space that you're interested in specifically. Okay, the researchers are there. Okay, you can even Google search, okay, who are the researchers doing work in your space in Alzheimer's and technology for me, right? We're now at the stage where you don't have to be on a research team that's just locally in your area anymore now. Okay, now there's an equity issue here. There are barriers. If someone doesn't have technology, they're not going to be able to participate in with some research teams. Okay, so that's another thing. But where I'm going with this is that it's just getting that 1, 2, or 3 people, as Trinity said, of networking, of connecting, okay, on social media. Say, hey, I love your work. I'm interested. You know anyone who's doing research in this? Can you help guide me to that? Okay, they're there. But where I started this was pick what you're very interested in. Okay, look that up, and then you'll find someone likely doing some work in that area, and then just reach out to them, and you eventually get on their list. They're very excited to have you on board. But I will also say diversify yourself as well to other research teams. Okay, there's this trap where many researchers and patients start becoming like a clique together, and I'm guilty of that in the past. And I said, no, I got to move on to some other researchers because I'm not always going to say yes to you, right? But then, oh my gosh, there's so many others that are doing cool stuff that I want to be involved in or I'm interested in. So it's out there. You just have to kind of like send them an email, reach out.
Yeah, absolutely. And, I want to now ask a little bit about, once you're a part of the team, difficult conversation to have is around remuneration. I'm going to throw this one to Trinity. If you're new to this and perhaps it hasn't been brought up or it's kind of been mentioned but not set in stone, how do we go about maybe having a conversation about it, or best practices that the researcher goes about this and makes it very apparent up front? But Trinity, I would love to hear a little bit more from you.
So ideally, best practice, everything is clear from the get-go. By the time you've heard about the position, you know what someone as a successful patient partner on the position would be getting for compensation. And to note, this compensation, if it's available, is always optional. Like, you do not have to take the compensation if it will affect like your status on disability or your taxes, things like that. And there are also other ways to be compensated outside of like financial means. So they could, for example, like sign you up for a course that would cost money or send you to a conference. And that is a form of remuneration as well that is important to recognize. But in the situation that you were referencing, where it's kind of unclear what's going on, I think a great way to ask about it without directly asking about it, if you're kind of shy about it, if you're not shy about it, just ask it straight up. And then it's on the researcher. And they probably feel 10 times more anxious about it than you do, because it's a them problem, not a you problem. So to ask that question puts it on them. But if you're not comfortable asking the question, that's completely okay as well. And what you can ask in that situation is, at the start of a research project or partnership, there should be a terms of reference available. And I'll put a link in the chat when I'm done about like a good way for organizations and research groups to make a terms of reference. But if this isn't available, then you should prompt the research team with, hey, is there going to be a terms of reference available? And if there has already been one available, then you can ask, is compensation going to be a part of this? How have you budgeted my time? And I like the one that Sarah put in the chat about how can you honor my time is another great one. So it just goes from there. And opening that conversation, and the more you do it, the more you get comfortable with it, but just recognizing that it's a researcher problem. You asking the question is whatever. Like, they hear tons of other things in their day that you don't need to feel bad for asking the question at all.
Thank you, Trinity. I think that's a good reminder. Do not feel bad about asking those questions. Ron, do you have anything else to add?
Yeah, there's been subtle ways that I've snuck it in, and when I realized that even when I'm not on the research team, but I'm seeing what's happening, I said, oh yeah, so you have a team and you have a couple patient partners. Yeah, and for all of you, majority of you, it's your paid day job. It's your gig, and you're getting, and I sometimes just make up numbers, but there's a point to this. I'd say, oh, some of you are getting $20, $30, $50 an hour, depending. Everyone in the room. Oh yeah, the patient, what are they getting, in the room, and everyone's getting paid to be in this room, in this meeting. But then the one that gets asked a lot of questions is that patient partner sometimes, that valuable. So then I let them try, I plant that seed to say, oh, are we doing anything for them? And then sometimes I blunt to say, is there some form of remuneration for them? But this is where we still need to grow. This is where I'm asking the young trainees, or you don't have to be young, but just the earlier trainees, to kind of say on your teams, start asking that question. Hey, is there a budget that we're giving for patient partners? Okay, that's the one who I think can start planting it. It may take a while still, but you're now planting those seeds to more the senior supervisors, researchers that haven't thought about this, are not spending the time coming to webinars like this to learn. That, hey, oh yeah, we should be putting in the budget something. I believe someone mentioned, and I think I mentioned earlier, that there are some groups that are already making it mandatory that, hey, we have a budget set aside and we need a patient partner for every project. And it's optional. Okay, so that is always saying, hey, we have a budget. If you're part of this, it would be 1,000, 2,000, if it's for 2 years, whatever that amount is. And then to say it's optional. Reason being is some patient partners are there because they want to just volunteer. They're not there for that. Some patient partners, it affects their tax situation. Okay, they might be receiving disability and actually they would prefer that I don't get paid for this, but somehow it's donated, or there's different ways it could be done. So technically they have to report it in Canada to CRA as revenue, technically. So but that option, I believe, every time there is a patient partner coming on research, that, hey, here's an option, this is what we can give you. Even if they didn't get the full budget, there should be something there, and it's your choice. And, I like what Trinity said as well, terms. There's some terms of reference there, that you guys have, how this is done. But those are usually more established researchers that have gotten to that stage now.
Absolutely.
Yeah.
But again, if you're a researcher and you're listening, it is up to us. We should be taking the first initiative. This is not on patients. But if you are stuck in that situation, speak up, speak up. All right. Next question is about lost engagement. And I know that
Alan, sorry. There was one question just there that I want to say.
Go for it.
Vincenzo asked a question, do members of CRA join this conversation? I think Annette or Elise, you guys actually at PAN, Patient Advisors Network, had a webinar with someone from CRA or working with patients. So if you have any information on that, please add that in for Vincenzo, just about compensation and CRA. I believe it's, if they're still online.
Thank you, Ron. And I do want to ask, so we've talked a little bit about patients can be engaged at different stages of research. And many of the times patients actually aren't in contact with what we call primary investigator, or perhaps, it's been 3 months and you're waiting for funding to come through. And contact hasn't been maintained or kept. How do we, for example, from patient perspective, reestablish that bond? Or is it from researcher perspective that we need to be reaching out, we need to be doing a better job of maintaining presence, maintaining our genuine and very authentic, need and want to engage this person? So I'm trying to look at it from both perspectives. If there has been kind of a loss in engagement.
Okay, I'll start there, Trinity, on that. So it's a relationship. So for me, any relationship isn't one-sided. It has to be coming from both. And you respectfully call each other out or check in with each other along the way. But that also has to be from the patient side. I'm going to start from there to know that, hey, you have some power in this. You're not just there waiting in the wings and being the little person, okay, that, well, I'll just wait for them. If you're comfortable with that and you prefer that, that's fine. That's the relationship. But if there's something that you feel that, hey, we didn't really communicate when there's going to be a check-in, or I haven't heard back, okay, or I don't know, or my email wasn't responded to, okay, we have to, in my opinion, teach patients how to follow up, how to do check-in, and also say, hey, I'm going to leave because it's not working out, okay? Patients can leave in the middle of their relationship if need be, okay, with that research team, okay? So, and it's up to you if you want to be honest and say, well, I'm going to be critical. You guys didn't communicate with me and all that. So I rarely see that happening. Patient partners doing that, they're just don't follow up and it just dissolves. But if you're really passionate about something, I think it's also the responsibility of the patient to check in. And vice versa. On the research side, I do believe if it's a medium to larger team, that there should be one or two team members that have a decent relationship with that patient partner, that they could check in on this person along the way. But it should be like a routine. Hey, usually it's based on meetings. Whenever meetings are happening, that's when updates happen. And that's where some communication in the emails or whatever should be coming through. If nothing's heard for a while, then yeah, it's just say, hey, here's the update to the team, okay, which will include the patient partner. And we're just at this stage right now, and this is why we're delayed. Or personally, researchers are also human beings. So we have to realize, hey, I'm struggling right now, or not struggling, or I'm just been bombarded with so much work that this project I kind of fell behind a bit. Okay, be honest. Okay, that's what I'm suggesting to researchers. Be willing to share, what's going on. That if you're struggling or if there's something that's changed, that supports the team. Communication is huge. So, Trinity, thoughts?
I honestly agree with everything, and really just prioritizing your experience as really worthy of the team, and like you're not like second best behind the researchers. Like you're truly an important member of the team. So to not be afraid to speak up, like as if it was any other situation in your life where you kind of fell out of touch and haven't got follow up on anything. This doesn't just happen in the research sphere. So whatever you would do in that other situation, you can apply it to this situation. The skills are transferable. And equally on the same note, there's just a question in the chat about if lived experience brings a perspective that academia can't achieve. And 100,000,000% yes. I think that it's a very, very stark difference. Even for me in university right now, for example, I'm doing clinical placements, and not to toot my own horn, but doing pretty good. And honestly, like 2% of how I'm doing is things that I've learned in school. The rest is things that I've learned from life. And all of that is from lived experience. And so whether it's something that you're doing in your job or in research, regardless, having that lived experience in any sphere is huge and something that academia can achieve. Like you can read about pain all you want, but if you've never actually lived with pain, you do not understand pain at all. So that's just one example, but really with anything, lived experience is like huge.
Yes, Trinity. And I'm going to add on to that. So there's this really interesting scenario that was shared in the Q&A. So individuals who were reviewing grant applications had, saw an interesting case. So researchers, academic researchers who are also patients with lived experiences had put down that they were patients with lived experiences on a research grant, it seems. And therefore, they did not have any independent, we'll call them independent or additional or other patient partners. So they were researchers, but they were also patient partners. So the question is around legitimacy. Would this, if you were reviewing a grant, I'm going to throw it first to you, Ron. If you were reviewing a grant and you saw this, would you have any prickling sensations, anything you would want to ask further? Because I also, truly believe in what Trini has said. It's two very different experiences. But if somebody really did have both, right? We also have to look at that side. So Ron, I'm going to turn it over to you.
So Ellen, you're saying wearing both hats, let's say. Sometimes I say we should have the hat that says patient partner right now, researcher, and sometimes you have those hats. My thoughts around this is that, again, it's just my opinion here, that the researchers that I've worked with that actually have a stake in their project, that they have that experience, okay, they're sometimes the more empathetic ones to me when I'm working with them, because they relate and you see their ability to kind of wear that different hat. But then they have to go back to the research side. Okay, so they'll say, okay, but we have to do this, Ron. This is how we're supposed to apply for ethics and all that. And so it's one where I'm trying to remember the key question here, Ellen, around that piece, but I just seem to feel like I relate better to the research team that has a little bit of personal experience, or a few of them that relate to what the patient is going through. Okay, so yeah, but I'm trying to remember exactly. Yeah, I'm just giving.
I'll clarify, Ron.
Yeah.
My apologies. So if you were reviewing a research grant,
yeah,
and you had academic researchers who had
Yeah.
also described themselves as patients with lived experiences, would you accept that, or would you question perhaps they need to have engaged other patients with lived experiences?
So you're saying the researchers are putting down that they have lived experience as well?
Yes.
Oh, I don't get that much then. Usually they just say I'm the co-PI or investigator, So they say researchers. I don't think I've ever had a mix where they're going back and forth. Yeah, so Trinity might have.
Trinity, go ahead.
Yeah, go Trinity.
I just have something to say about that. Absolutely, it's a great perspective that the researcher could bring, but this is an issue that we see a lot in patient-oriented research, where there's a really big lack of diversity in patient partners. So if it's the researcher who has the condition, that means they're already the most educated of the most educated about their condition. They're a researcher, they're probably not living on a disability income. And they're doing well with their condition because they're able to be the researcher and primary applicant or whatever on the project. Being a patient partner and part of the patient partner group, it needs to be a diverse group to avoid that tokenism and to get those diverse representation and ideas and opinions. And if the only patient partners on the project are coming from people who are also researchers, that's great. And that's a great perspective to have. But you do need people with different life experiences as patient partners as well, who aren't researchers. I think that that's a really, really big thing that's important.
So no, I love Trinity that you're sharing that there, because I really don't have that where they put themselves as a patient partner, but I might know their story, the researcher. Oh, you're also a caregiver to a parent with Alzheimer's or dementia, but they're wearing their research hat pretty much as they can, right? And in our meetings, they try not to give their opinion, okay, when they take it out. I've seen the other way where patient partners actually become researchers. Okay, so I'm one of them where, hey Ron, okay, we have you as a patient partner, at the meetings, but could you come to some of our interviews and be like a research assistant, okay, patient partner, okay, where I'm there now and helping translate live or help ask the questions that, I could ask that will make more sense to the population that I know much better. Or let me ask the question what you're asking in a different way. So I just want to say that there, that I've seen it more the patient partner becomes more involved and becomes that junior researcher. So, yeah. So
Really, it gives us such excitement as we move forward, because what we're seeing is that we're having these really hard conversations because the lines aren't so clear anymore, and they've never been really clear. We've just tried to delineate them, falsely delineate them, but now there's so much rich nuance coming out. There's so many, you're seeing all of these borders, blur, and there's opportunities for everyone. So I apologize if we didn't get to your specific question in the chat. I do have to wrap up. Ron, I will go to you. But I will say that we will try our absolute best to get all of the rich information from the webinar chat to you in any best way we can. But I do have a few closing remarks, so please do not go. Ron, I'm going to turn it back to you really quickly before I
just want to compliment everyone here. I've been struggling keeping up with all these comments. This is very rare that, and all the comments are not just backing up each other, but so valuable questions. Some of it's just coming to us as the host and panelist that doesn't go to everyone, but I'm saying, holy crap, these are like excellent conversations. There's not enough time in this one session, so just everyone to understand. And the one comment, I can't recall who said it, that they're kind of new as a patient partner. Please don't be overwhelmed. Take your time in whatever works for you. There's a lot of stuff here that you're hearing, yes, but it is something that, we're glad that you're contributing, and make sure you're getting something out of it as well along the way. So, but yeah, so much great, stuff that's being communicated here that we didn't get to. So thank you, everybody.
thank you to everyone, and we will absolutely encourage you to please complete our survey. Please, please, please share your feedback. We are listening. We want to do better. We want to continue, want to improve. So I'm going to highly encourage everyone to complete the survey. And if you have not done so already, please join the PxP mailing list, as there will be 3 more webinars in this series. The next one is about motivations to be a patient partner. And with that, I'm going to just give a huge round of applause to Trinity and Ron. You guys, I've learned so much from you. I've learned so much from everyone who joined us today, and I just cannot thank you enough. This has been such a meaningful and impactful experience on my own journey as a researcher. And with that, I'm going to say see you at the next webinar. We are at time, so I am so sorry. We have to wrap it up, but thank you, thank you, thank you to everyone who's made this possible.